In today's session, you'll be hearing from me as well as my colleague, Dr. Jesse Green, also a research assistant professor here at The Ohio State University Nisonger Center. And we'll be focused on sharing some information on accommodations and communication supports for effective psychotherapy. Our learning objectives will be to help you identify different types of accommodations. What does that mean? How to apply communication supports that are tailored to meet individual needs, including the incorporation of visual and multimedia tools into therapy, as well as using plain language and accessible formats. And then finally, collaborating with support people as an essential accommodation as well. I'm going to transition my share again. I'm going to invite Dr. Green to introduce herself as well to you all, if she's prepared for that.
Sure. Hello, everyone. As Andrew said, my name is Jessie Green. I am a faculty member here at the Nisonger Center. I come from the K-12 setting initially as an intervention specialist. And so a lot of my work is around how folks transition out of the K-12 system into adult life, whether that's into post-secondary and through, and also around employment for folks with most significant disabilities. Thanks, Andrew.
Yeah, thank you too for joining today and presenting this information. Similarly, we have a bit of a similar background and coming from the education space. I started my career in education and an autism service provider, teaching middle and high school students diagnosed with autism spectrum disorder before transitioning to research team at the Nisonger Center. So it is an honor and a privilege today to be presenting to you on implementing accommodations and supports in psychotherapy for adults with intellectual disability, and really framing this as an interdisciplinary approach where we're going to take some of the strategies that Jesse and I have come to be familiar with in education and applying that into psychotherapy. I'm going to begin the slideshow for us. Right, so accommodations and supports as imperative strategies for inclusion and improved outcomes in psychotherapy. Of course, we know the background that from research, we do have an understanding that adults with intellectual disability have a increased risk of experiencing psychiatric disorders and mental health conditions. And there's a lot of barriers to proper diagnosis and being able to access therapy in this population. And those differences that can affect communication even include adaptive functioning differences and how we understand conceptual, practical, and social domains of communication and daily living, as well as those differences in social communication and interaction. There's also this concept of diagnostic overshadowing, where oftentimes in the medical field, individuals with intellectual disability, when they are exhibiting behaviors, those are more quickly attributed to their intellectual disability or their cognitive impairment than to some potential underlying concern, such as a secondary health issue, and then, of course, potentially mental health conditions. We know that there is limited clinician training. So just by taking part in this ECHO series, you're all expanding your knowledge and your awareness to be able to engage with this population more effectively and then continue to share that out with colleagues. So we, again, appreciate you being here to really address this barrier specifically, as well as what we know as systemic fragmentation between different systems. So we have our mental health system, and then we have our developmental disability system at state levels. There are agencies and organizations that are serving this population, but oftentimes more directly as opposed to crossing over and supporting each other through person-centered planning and supported decision making, coming together as representatives from each of these agencies to serve these individuals within this community. We do know that accommodations and supports are really essential to ensure equitable access to effective mental health services. So that one really important part about increasing your training really supports this idea of overcoming the barrier of incompetence. And so within the realm of intellectual disability competency, it's important to understand that there are variable cognitive capacities and information processing speeds. Of course, that's true of all of us with natural variation of neurological and brain functioning and information processing, but it is really advisable when working with this community to be patient, to check regularly for understanding, asking individuals to share in their own words what it is that they've been taught in psychotherapy sessions. Frequent breaks is also recommended. And then also encouraging aspects of self-advocacy to ask questions, to seek clarity and request help whenever there's feelings of confusion or feeling overwhelmed. So really supporting that self-advocacy. And believe it or not, these are very simple types of accommodations and supports when serving this population. Here's a quick operational definition for accommodation. What does it really mean? Broadly, it's any adjustment or modification that's designed to remove barriers and ensure equitable access to environments, opportunities, and services. So, specifically, this could be accommodations to support communication. Simply, this could be clear language or plain language, simplifying information and explaining it. Um, we can describe something complex like cognitive behavioral therapy or cognitive restructuring in ways that break down that information, explain it, um, not lacking detail and not dumbing it down, but explaining it in ways that are clear and understandable and accessible to individuals. You can also use visual supports to help with that, as well as assistive technology. All of those things can enhance the accessibility of psychotherapy. Person-centered planning and client-centered care are also ways that we think about improving accessibility and accommodating individuals within this community. It can help support also autonomy through supported decision making, helping them make informed choices with other people, giving them their advice or their opinion on different options that they might choose from. And that can really support this aspect of self-determination. And of course, self-advocacy and determination is a session that we'll focus on later in this series. There's also ethical considerations here too, in supporting autonomy, dignity, and respect of every individual. We want to make sure that individuals, even those with guardians, understand and have an informed consent to participate. And so that can be a very confusing process about what does it mean to be sharing, personal information in a private session like this, especially if we don't give people the permission, the ability to say, yes, I want to be here for my own sake, and yes or no, I would like someone to support me in understanding or making decisions through this process. So all of those things are very empowering to improve outcomes for this population. Let me pass it over to Jesse to talk a little bit about supported decision making as we understand it through person-centered planning and client-centered care.
Yeah, thanks. And so when we think about how do we provide that autonomy to our clients, that dignity and respect, supported decision making is one of the frameworks that we use for both person-centered planning and client-centered care. And so these frameworks have some legal standing behind them. So if you'll hit the next slide, Andrew. Here in Ohio, what the law reads is that supported decision making is used as an auxiliary aid and service. And so, what that really means in practice is that it's going to support disability broadly. So that could be cognitive disability, a developmental disability, or an intellectual disability. That could be a physical disability, really to support that accessibility within the mental health setting that you're practicing. And so that could be adjusting the format of how you practice, communicating differently. And Andrew's alluded to that, and we're going to talk more about that later on. This could include interpreters, having readers, whether that's you or an electronic reader, presenting materials in a variety of manners so that someone is able to best access that information. And then, really, when we think of the self supported decision making model, sorry, my acronyms got the best of me. Um, a lot of times we're thinking about folks who maybe have guardianship or are considering guardianship, and using a supported decision-making model can build that independence for someone if they do have guardianship, or it's at least a less restrictive means to guardianship for folks. And so some of the other laws, if you'll head to the next slide, Andrew, that we think of in this space are Section 504 of the Rehab Act of 1973. And really, this again goes hand in hand with supported decision making, as it really looks to make access to services, supports, the environment equitable and equal. And so this could include things like evaluations and treatment methods in mental health settings. We also have the Americans with Disabilities Act of 1990, which really makes sure that the physical spaces that folks are in, or in this case, it could be digital as well, are able to be accessed with reasonable modifications. That reasonable modifications becomes a little bit of a gray space in the law. And so we're going to talk through some of those accommodations later on. And then finally, for our folks who are still accessing those K-12 services, we have the Individuals with Disabilities Education Act, which was last amended in 2004. And that gives students the opportunity to access supports such as mental health counseling, behavior therapy, social skills training, as well as their academics and extracurricular activities in the K-12 system. So I'll pass it back to you, Andrew.
Right, thank you. So, even though we obviously have an ethical imperative to serve this population, even though we have these legal mandates, we actually need to, commit to action to actualize these. And so let's think a little bit more about some common ways that we accommodate students within this space. And this is the art and the science of pedagogical supports, or, things in an educational space that are common in supporting students with intellectual and developmental disabilities. So here are some common examples of utilizing assistive technology, like augmentative and alternative communication devices, or AAC as they're otherwise known. And interestingly, when we think about technology, our brain first goes to digital and electronic types of devices. And while text-to-speech devices and communication devices are essential, this could also be picture boards where individuals point to certain pictures in order to indicate and communicate their needs nonverbally. We think about behavioral and emotional supports. A common strategy within school systems is PBIS, or positive behavioral interventions and supports. And there's three tiers where we have kind of a generalized strategy for the entire student body. And that's just establishing expectations about what type of culture we want to establish amongst our community within this school setting. So oftentimes there's an acronym that schools will use that spell out certain virtues or expected behaviors, and then more targeted interventions as you go up into a tier 2 and a tier 3, where you're providing more individualized support for smaller subgroups of students. We also have instructional and organizational supports, including co-teaching and even peer mentors, as well as visual schedules, checklists, and reminders, as we've mentioned previously, and social and communication supports, where clear language is, highly emphasized, but also providing specific training and social skills. If this is an individual's first experience in this new type of clinical setting, you might even provide some introductory training on what is to be expected within that therapy relationship, just providing information about how you will provide psychotherapeutic education. You will be asking questions. And so really just establishing some baseline understanding of what this new environment means and what is expected between the clinician and the client can be a helpful way to get started. On the screen now, we just see a graph of just common academic accommodations used by students. And while some of this doesn't directly apply or translate into a clinical setting, you can get a sense of the types of supports that K-12 students are utilizing so that as they emerge as young adults or out into their adulthood, these are types of things to keep in mind. Extra time on assessments is just one thing. And so just generally thinking about providing extra time, knowing that, traditionally or typically you might get through all of this content within one session. Well, that might take 2 or 3 sessions to get through introductory content with an individual with intellectual disability, as well as tutoring and remedial classes. So, really breaking down complex therapeutic strategies into more manageable tasks and steps can be important to keep in mind. Generally, in education, we also talk about differentiation, individualization, and personalization. While they all sound very similar, there are
You
slight
too. Bye.
nuances, how they're different. So in differentiation, we think about being multimodal, right? Not just speaking, but also showing a visual. Individualization, where we exercise flexibility in assignments and assessments. And that could be, how we think about how we would traditionally assign homework or practice strategies in between sessions. We think about how can we be flexible here, as well as personalization, which is really offering different choices. So, you might offer them different ways to practice, whether it be journaling or tracking information by hand in a handwritten journal or worksheet versus maybe tracking some of the data using an app or another digital tool. We can also think about universal design for learning here. In fact, within the framework of UDL, there is a specific um, concept intersection between engagement and executive function that's labeled as emotional capacity. So within these UDL guidelines, you can link out and get a little bit more information about some ideas here where you might, for instance, help individuals develop awareness of their self and others. Of course, a critical aspect of that, emotional development and regulation. And so there are great strategies within UDL to consider, like using, as we mentioned, differentiated models or scaffolds. The fourth bullet point down here talks about how do we appropriately handle phobias and judgments of quote unquote natural aptitude. So we think about, how can I improve on the areas I'm struggling in rather than I'm not good at math? Well, this is to me like a direct example of that cognitive restructuring, thinking about strategies to reframe negative thoughts into good thoughts. I'm going to pass it to Jesse to talk a little bit about employment accommodations and supports in the workplace.
Yeah, so Andrew was talking about academic supports, and typically we think of the K-12 setting. In that K-12 setting, those kids grow up and they become adults, and hopefully they're moving into the workforce. And so there are some things that we can do to help support adults with disabilities in the workforce that we'll talk through briefly. And you'll notice some kind of threads that move from academics into the employment arena. And so the cost of reasonable accommodations is often the critique of reasonable accommodations. But what we know from the research is that that's actually not true, and that most of our accommodations cost under $300 or less. That's 94% of accommodations are that they're free or under $300. And so when we think about those things, we're looking at several different categories. On the next slide, Andrew. So again, assistive technology, hopefully we've figured out something in the K-12 setting that works for folks that we can move into the employment setting. Maybe not, but that's okay. It could be different equipment now or additional communication aids that someone is using. We could also be looking at the job itself and restructuring or removing specific tasks. You've maybe one of the words that we've used in the past was job carve for this. And so we're taking a certain set of a job description and we're either removing some of it or we are pulling new tasks from multiple job descriptions to make one job, a new job description that meets the strengths of an individual. We might be looking at the day and the location where an individual is working. And so we may need to adjust the workspace to reduce distractions or make it more accessible if there's a physical limitation. We might be thinking about the day and how it's structured. And so some of our folks need more break time or at least very structured break time. Some of our folks may need to do some hybrid so that they hybrid work so that they're able to really monitor their masking levels and so that they aren't burning out. We might need more flexible hours. Again, support services, and this looks like coaching and mentorship. This could be natural supports from a coworker or a supervisor. We may need to do workplace training a little more frequently to make sure, especially when it comes to health and safety, that someone is meeting the requirements of that portion of the job. And then finally, we may have some policy adjustments that are made for someone in the workplace. And so on the next slide, we know also when we implement employment accommodations that we have higher retention rates for employees with some sort of psychiatric disability. And then you'll see linked on the slide is some references to that. And so when we think, you can go forward, Andrew, sorry. You might be going, how do I figure out what accommodation might work for someone at work if they're coming to you struggling at work? One great resource is Ask Jan or the Job Accommodation Network. And I've put the link in the chat as well as we've got the QR code that takes you there. And you can do an amazing search of both disabilities and accommodations for or with folks. And so if we go to the next slide, we've got some screenshots that we'll briefly work through so you can search by disability. You can see on the screen, this is just a screen grab, so there are lots more disability types that are there. And we can search by that, and then it drills us down into what is it we're looking at. Are we looking at the cognitive function? Are we looking at physical access to a space? And we can drill down until we get to a series of suggestions. Now, you may have to trial these suggestions to see what might work. You can also think back to the K-12 days and what might have worked there that we can take and generalize into the employment setting. And so when we, this support person is one example that came up from that search. And so it gives you what that support person might do for the individual with a disability. I will toss it back to you, Andrew.
Thanks, right. And I really appreciate how you said like how, we're talking about academic settings and then we're talking about employment settings. Well, how does that translate into a clinical setting? So we're going to get a little bit more specific with some examples of evidence-based pedagogical practices. But I like how you put it, right? We're trying to generalize what has worked for individuals as youth and young adults and applying some of those strategies now into this different setting. So this is where we would like to, share this interdisciplinary approach to effective psychotherapeutic education, and how we can adapt that education to accommodate, support clients with intellectual disability. So here's some examples. And one that's, kind of right off the bat is this concept of reinforcement, something that we tend to do kind of naturally in our day to day, but being very proactive and intentional with how we reinforce and apply consequences following behaviors to reinforce and increase the likelihood that those behaviors will be reused and then really generalized across different settings. And so examples of this are just providing praise and encouragement, being very specific. Again, once a behavior, you've noticed a behavior or a knowledge or a skill that you've taught being used, being very specific and praising that so that it gets repeated. And then maybe even thinking about how do I apply a tangible reward and a concept that we use in K-12 settings, like a sticker chart, where you earn stickers, towards maybe even a greater reward, might seem kind of infantile in some cases. So in some cases, that may not be a good example. In the field too, we often use edibles as a tangible reinforcement. So you might even just work with the client. What isn't reinforcing to them, and think about some sort of a reward system to encourage that engagement and interaction. Another example here from education is this concept of task analysis, this process in which a more complex activity or behavior is just broken down into smaller, more manageable steps. So that it's easier to teach and assess that targeted knowledge or skill that you're teaching. So here's an example of cognitive restructuring that's broken down into multiple steps. And then you literally just work on one at a time, defining emotions as this initial step of being able to name it to tame it, for example, and then moving forward throughout the steps. And so that moves us into the next process. But if we have time, I'll kind of take you out to this website. It's called Goblin Tools, and I'll add the link in the chat. But one of the apps within this software is called Magic to Do. You can actually break down, as you can see here, I entered cognitive restructuring. And what's really fun about this is you can adjust the spiciness level. So you can see I've circled the chili peppers. You can actually make it more spicy and increase the number of steps in that more complex task to a greater number to break it down even further. Or you can reduce the spiciness and make it a little less steps. That task analysis of defining the steps leads us into chaining that I'll have Jesse speak about.
Yeah, so Andrew was mentioning with the cognitive restructuring of taking one step at a time and adding as someone is successful. And that is essentially chaining. You can start with the beginning or you can start at the end. You can do the whole thing together. And you have to know your client to make the decision on or the task at hand that you're teaching of what the best one is. So, for instance, I'll use a non-therapy based example is that you might be teaching teeth brushing. So it may be that you are just having the person you're working with get all those tools, the toothbrush, the toothpaste, get them out, and then you do the teeth brushing, or vice versa. You do all the teeth brushing and then you get to the end and they are rinsing the toothbrush off after you're done. And so that's the idea of chaining is you're chaining one step to the next, but you may be taking on some of that role initially until someone is able to learn all those steps. Another accommodation that we use often, and I feel like is becoming more coming into practice more often, is using computer assisted instruction. And so this may be using apps that are either already built into our phones or that we download and pay for to have that support for emotional, regulation training that we might be doing with an individual. So thinking about breathing sequences is one that we often see in the form of computer-aided instruction.
And it kind of leads us into modeling, and video modeling as kind of a very similar type of aspect here. But modeling, of course, is just demonstrating. kind of mimicking yourself. And again, you see how there's some overlap here because we have one towards the end that'll talk about simulation or role playing. It's really an example of modeling, and then just using videos and computer assisted instruction as an example of video modeling. But these are effective evidence-based strategies that have been shown through research to help improve the acquisition of knowledge and skills for the population. So an example here might be box breathing, where the therapist is teaching the technique through a physical demonstration and then showing a short animation to supplement the learning as a multimodal guided experience. And here's an example here of the modeling here where we have a client that's learning how to use deep breathing techniques to manage their anxiety. And so we use an image to represent box breathing, as well as introducing a video for that skill as well. So we're breathing in, we're holding, breathing out and holding. And so with all of this multimodal type of instruction, we have different ways to better understand and then replicate that ourselves. And then we can have a discussion. And then again, we offer reinforcement, encouragement, and prompts as needed. That's also an example, I think, even in the name box breathing is an example of a mnemonic type of device or a memory device to help people, remember. So, mnemonics or memory devices are just learning aids that can take many forms. So you could have an acronym that spells something out or some sort of other visual or acoustic cue. And so again, we use box breathing here as an example where the square visual reminds us how to practice this technique. Just,
Yeah, and so another strategy is prompting, which could look multiple different ways. We could verbally, with our words, do some prompting. We could do gestural or visual. So I am, pointing to something on the table. Visual might be a picture, like the modeling and the mnemonics that Andrew was just talking about. We might be doing hand over hand again. If we're doing hand over hand, hopefully you're seeking consent to do that with your client. And so with the example of name it to tame it, we've got not only a mnemonic with the rhyming of the title, but then that helps to trigger that verbal prompt of, okay, if I use name it to tame it, I can now acknowledge, label, and process through the skill or the emotion that I'm working through at the moment. And then with self-management instruction, Andrew's talked about this a little bit as well, that we can use lots of different tools to self-monitor and self-manage how our skills are going. That could be charts that we are tracking that are paper or pencil. We could do that digitally. We might be journaling different types of skills and how it's going. We might be doing that again on paper, old school, or we might be doing that digitally in the notes of our phone or our iPad, depending on the technology that a client has. And then we're able to look at the past in review for how to move forward. And then finally, the last practice that we'll review today is simulation and role playing. And I think that this is a common one that folks use already. We can really model real life scenarios that trigger negative emotions or anxiety. We can really work through some of those situational based uh, skills that an individual might be working through. Andrew.
yeah, thanks, Jesse. So yeah, I think some of those things, right, are already commonplace and happening in practice. And hopefully you were exposed to maybe some new ideas that got the gears turning about things that you might embed in your own practice to make it more accessible by applying accommodations and support. So we kind of talked about this importance of client-centered care and really focusing on empowering the individual to be actively engaged in their own process. Well, that starts with feeling like you're included, feeling like you understand that you're on the same page, and you starting with clear language, starting with basic instructions of this is what therapy is, this is what you can expect from me, and this is what I would expect from you, and building that relationship step by step, really tearing it down and building it one brick at a time through tailored accommodations, evidence-based practices that we know are effective in educational settings to make a bigger impact on our clients with intellectual disability.
And so when we think about the future of this work, there's a few things that come to our minds of what we can be doing to move the needle. And so doing some randomized control trials on the effectiveness of different CBT protocols, specifically when it's with clients who have an intellectual disability. Again, the use of technology. We enjoy technology. You can tell from some of the examples that Andrew and I share, but we don't know what works for whom and under what conditions. And so doing some work around that would be helpful. Developing more psychometric tools to assess the symptomology of folks with ID, and then really evaluating effectiveness between group and online therapy formats. I think that's a question that the folks that I work with in this space get asked often. Well, I don't know. Will a group setting work for this person? Or, is online okay if I can only find an online practitioner versus someone who's in person? And we don't have research necessarily yet to back those answers. We have to go off of our anecdotal experience.
And so this is our call to you to work together, to really leverage the next several weeks that we have in this community of practice to think through some of these complex issues to create a more inclusive and accessible mental health care system for all, to really reinforce those practices that you notice that you're already doing, and maybe find a new one to start integrating into your practice over the next year. And then just, build and generalize those skills over time by continuing to adopt accommodations to increase engagement, improve outcomes, continue to boost your competency within intellectual and developmental disabilities. And when you hear about research studies, consider um, engaging in those studies as a participant and helping researchers identify clients that might be interested in participating in research as well, so that we can continue to better understand what works. So we have some resources that we'll end with. We do have a video on our website that's available in these slides, also on our NICE RRTC YouTube playlist. We have some clear language summaries and tools for clinicians and clients to build their relationship together. And finally, our funding acknowledgments. We have maybe a moment here for a question or something that anyone would like to echo. Christine, I see your hand raised.
I'd like to share that sometimes the clinicians need to know that um, people have some guides in their own ISP or their own plan. Like, for an example, um, if it's saying like my clinician will contact um, me with 48 hours early before if you need to cancel. Now we understand there's last minute emergencies. I get that. But I mean, if the schedule cancels because of a specific event, um, it's important to contact the individual for two reasons. Number one, because that's to show honesty, that you're not gonna try to make them drive to the location when you wouldn't be meeting with them. Okay, is my honest answer. And true, second, it shows respect because um some people would feel that if the psychologist was not connecting early enough, then it makes them, the individual, feel not respected. So I just want to point that out, okay? Because I've had experience where the psychologist has canceled on me, and it's happened more than twice, okay? And there's a difference between once versus a pattern, okay? So I just wanted to share that.
Yeah, thanks, Christine. Appreciate that. I see, and please correct me if I mispronounce Anastasia. You have your hand
Yep,
raised?
that's right. Yeah, this is really helpful. So thank you all so much. I'm specifically interested in any resources that I can use to find visuals to enhance my psychotherapy with. And then I have a specific interest in any work basically what I'm looking for in one context is a handout that explains Spoon's theory, maybe even a good video. And then if anybody has like a really good worksheet where clients can track both their spoons and also the things that re-energize them. So thank you for the
Oh,
question.
that's great. Yeah, appreciate that. I mean, believe it or not, I just used some generative artificial intelligence to create that image that I showed with box breathing. So I think we can really leverage this software now to kind of create our own visual supports, which is, we're on kind of the cutting edge of that. It is kind of hard to find images as well. I think someone had mentioned in the chat, can you do a self video? And sometimes that's needed because the person in the picture isn't me. It is hard sometimes to generalize that. So I would say, kind of use the software. We do have some additional images on one of the worksheets that I did link out to as a resource. And then I want to open it up to the team about the Spoons Theory worksheet or resources. I'm looking around to team members to see if they might
Yeah,
have an
I
idea.
see Rebecca said that she does have some materials. Anastasia, if you want to email them, they put their email address in there. And I also just popped in the chat. My supervisor hung the Spoons Theory paper on my office door. And it's a nice little visual that kind of teaches it really quick. So I just sent her a message asking where she got that. And I would be happy to send that to you as well.
Thank you. Very helpful.
Yeah, and we'll continue to search for resources that we can share out over the next few weeks. But yeah, wouldn't that be a great idea if we can really work together on creating a library of those types of resources? Patrick in the chat mentioned the Hoberman sphere to teach breathing, something that's kinesthetic and hands-on, another great idea. With some other great examples here. So appreciate everyone's engagement. I recognize we're a little low on time and want to move into our case so we have enough time to discuss.